Hi guys, we're going to talk about fluid and electrolytes. This chapter is going to really talk about why is it important to review our lab results. The night shift draws labs on the patients around 4 a.m. and you get those reports around 7. You review the labs to start your day. So why is that such an important aspect of our job? What does it tell us? It really tells us about our electrolyte and that balance. It tells us the general status of our patients. We are focusing on the fluid and electrolytes today, which is a fundamental skill that you will use every time you work with your patients. Fluids surround all the cells in our body. This fluid is called our serum. So why is that important and what does it do? So let's get started here. This is why fluid is important. In our body, we don't call it fluids, we call it serum. This slide tells us what the liquid portion of our blood does. And if I don't have enough, then it alters our homeostasis. So our serum transports nutrients to cells and wastes from the cells. This is a major function of water in the body. It transports hormones, enzymes, blood platelets, and red and white blood cells. What do our red blood cells carry? It carries our oxygen so that we get oxygenation all over. All of these are transported around the body where it needs to be. So we have to think, what if I don't have enough blood serum or we are dehydrated? What can happen to us? Can we die? Absolutely. We call that hypovolemia, which leads to shock because we aren't getting the nutrients, red blood cells, white blood cells, to the areas of body that need it. It facilitates cellular metabolism and proper cellular chemical functioning. Nothing works if there isn't enough fluids. It acts as a solvent for electrolyte and non-electrolytes. It helps maintain normal body temperature. It facilitates digestion and promotes elimination, and it acts as a tissue lubricant. Water is the most important nutrient in our life. Although a human can live several days without food, humans can only be sustained for a few days without water. It's just that important. So let's talk about where that water is located. There are 2 compartments of fluid within the body, intracellular fluid and extracellular fluid. Intracellular fluid found inside the cell is about 70% of the fluid in our body. Extracellular fluid is outside the cell and constitutes about 30% of the fluid. And then this is divided into 2 major divisions, blood or vascular system, and then interstitial. And this is fluid found between the cells, but outside the blood vessels, usually in those lymphatic channels. So if you have a patient with lots of fluid found between the cells or interstitial, like in their ankles, that's going to be called edema. What of your body weight is water? About 50 to 60%. A healthy young adult has more muscle mass. Does muscle have more or less water than adipose tissue? It definitely has more. That is really important because young healthy adults, and if you're a young healthy adult, you have lots of muscle tissue. Your risk of getting that out of balance is pretty low. But what if you are an older woman? I say woman because we have more adipose tissue. If I get dehydrated, do I have more side effects? Absolutely. I have more adipose tissue, less stored up, less muscle mass, which puts me at higher risk. An infant has considerably more body fluid and extracellular fluid than an adult, but they're more prone to fluid volume loss. Females and obese patients have less body fluid. This is why men can work out and lose 5 pounds in a day because they have more body fluid. And this is just another picture that's showing that total body fluid of a normal adult, remembering it's about 50 to 60% of our body weight. So why do we need to know the difference in isotonic, hypertonic, and hypotonic fluids? The first one we're going to talk about isotonic, and that's same concentration. You can see the normal cell in that top left. If I'm going to give an isotonic fluid, what does that mean? It means it has the same concentration and the same amount of electrolytes inside the cell as out. So what happens? Nothing if I give this fluid. The shift of fluids in and out is easy, and it creates homeostasis. The next one we'll talk about is hypotonic. That's a lesser concentration of particles than plasma. So I want to give a hypotonic. It is more or less concentrated. And we've already said it's less concentrated. The electrolytes aren't going to shift. The fluid will shift in. Could that be a problem? It can be. Think about your marathon runner that didn't prepare well for the marathon, just thought it would be fun to go out and run. So they get 5 miles in and they're starting to get dehydrated, and it gets worse and worse. Your cells have shrunk, and this is the fluid you would give. It's going to put fluid back into that cell. Too much of that fluid could rupture the cell, so we still have to be mindful of our hypotonic solutions. And the last one we're going to talk about is hypertonic. Remembering this is opposite, it's the greater concentration of particles in plasma. So you will see these fluids given much more often. If we give a hypertonic solution, does this mean we have more or less electrolytes? And we have more. Now I have more electrolytes outside of the cell than inside. The fluids shift out in order to maintain homeostasis. Could that be a problem? It can be a problem. We may have to give them a hypertonic solution because they have had too much fluid, and we give it to shrink down the cell. But what if I give too much? Then it could severely damage that cell. These solutions can be scary, and we don't give them for more than an hour because of the risk of damaging that cell. So when you're giving fluids, you should always think, is this hypotonic, isotonic, or hypertonic? And that will tell you what's going to happen when you administer. It's going to tell you what's going to happen to those cells when you administer it. So let's get familiar with some of the type of solutions for each of these. Normal saline is isotonic, where half normal saline is going to be hypotonic. It's half, right? So it's less concentrated, so that should help you clue you in that it's hypotonic, right? That should make sense. Lactated ringers is most closely related to our body fluid. When we think about those isotonic fluids, it stays in that intravascular space. Dehydration, fluid loss, diarrhea, vomiting, electrolyte loss, burns, labor and delivery, those would all be types of situations we would be giving those isotonic fluids. Hypertonic is going to pull fluid into the extracellular spaces. So if we have a patient in DKA, shock, maybe their blood sugar levels are wonky, we're going to do a hypertonic. If our patients are NPO for surgery, we may want to give them a little dextrose to maintain those blood sugars. Hypotonic is going to shift those fluids from the extracellular compartment into the cells because the solvent is more diluted. So GI loss, fluid replacement would be some examples of when we're going to give those hypotonic solutions. And again, here's just another slide to differentiate between our isotonic, hypotonic, and hypertonic solutions. So what are some other things fluids do for us? Fluid is not just about intake. It can also be about absorption. We are, and we're absorbing it, if we're absorbing it correctly, and distributing and eliminating it. As a general rule, how much should I take in and put out? We talked about that back in Concepts 1. We should be taking in about 2.5 to 3 liters, and that really should be what we're also putting out. What are examples of patients that may not have that much in or out? We can consider our kidney disease patients or even our cardiac disease patients. They may not be able to take that much in because it's going to make their disease processes worse, meaning they're not going to put that much out potentially either. These patients can't take that much in because it may not distribute well. The extra fluid could go into the interstitial spaces, meaning the lungs, the abdomen, or even the feet. So how do we take fluid in? We can ingest liquids. We can, which means water, hopefully, that's the main one you're taking in. We can take food. Some of our liquids come from foods. Fruits and veggies have lots of liquids. And the metabolism also comes into play. How do we lose fluids? Our kidneys lose fluids with urine. Our intestinal tract loses fluids with feces. Our skin loses fluids with perspiration. And then we have those insensible water losses. Those are the ones that we're unable to record. Breathing, we can lose fluids. So you can calculate about 300 to 500 mils of fluid loss just by breathing alone. So what patient population would lose more? If you think about your tachypnic, right? We just said 300 to 500 mils of fluid are lost by just breathing. So if we're breathing fast, we're going to lose more. Our febrile patients can also lose extra fluids. And then what is abnormally via vomiting, wound drainage, and hemorrhage? Those would all just be recorded, right, as fluid loss, depending on if you can catch that. Because we know that they have essentially the same amount in as they have out, we need to make sure this is true. So how do we do this? We can do this by keeping an intake and output in a 24-hour period of time. If they are not equal, we need to determine why. We can do this by doing some daily weights. That's usually a very good indicator of our fluid status. A normal person can only gain about half of a pound by overeating. So if more than that is obtained, then we might be considering retained fluid. We remember that we are always measuring our weights in kilos. So make sure if we're measuring in kilos that we're also looking at it the next day in kilos versus pounds or pounds. And then our fluid loss or retained is going to be equal to liters. Make sure we're accurately weighing the same time each day with the same scale, the same clothes, all that good stuff that we've talked about. Fluid intake and output measurements, when we talk about intake, right, those are our PO fluids, our full liquids, tube feedings, IV infusions, maybe some of those piggybacks. And then our output is going to be urine, diarrhea, vomit, gastric suction, wound drainage. So remembering that when we're doing our daily weights, right, same time, same scale, same bed, zeroed out. If they have a weight gain of more or less than a kilo, we probably should reweigh them. Maybe think about restricting some fluids. Make sure we call the provider. They may order some diuretics. So fluid imbalance, if we're talking about deficit, that means there's too little fluid. So take a minute and try to define each of these on your own. The first one is blank is caused by a deficiency in the amount of water and electrolytes in extracellular fluid with near normal water electrolyte portions. The part that is important here is I've just lost sodium or potassium. I'm losing everything in the same ratio. So that is actually hypovolemia. And it often happens with vomiting, diarrhea. It could be a blood loss. The second one is blank, is a decreased volume of water and electrolyte change. So this means the ratios are different. They may be losing one electrolyte faster than the other. So the answer here is dehydration. And then that last one here is what is distributional shift of body fluids into the transcellular compartment, such as the pleural, ascites, pericardital, joint cavities, bowel, or excess accumulation of fluid in the interstitial spaces. And that is actually called third spacing. The third space is that interstitial space. So let's go in the opposite direction. I'm going to give you a minute to look at these now. And we're talking about fluid imbalances, excess, meaning too much fluid. So blank, excessive retention of water and sodium in the extracellular space. And that is hypervolemia. Remember, it's the same water and sodium at the same rate as hypervolemia. What about blank above normal amounts of water and the extracellular space? And that is dehydration. And slide 3 is the excessive extracellular fluid accumulates in the tissue spaces. And we kind of talked about that earlier. If it's in those tissue spaces, like between the cells, then that's considered edema. And then that last one is interstitial to plasma shift. And that's just that movement of fluid from space surrounding the cells into now our blood. So let's talk about clinical manifestations of dehydration. What are those signs and symptoms that we're looking for? How do we know if our patient is dehydrated? Our patient shows up for a random assortment of symptoms, and it could be because of dehydration. We just need to figure out what are those symptoms. So here's my first question. What is the impact on the pulse? Is it going to go up or is it going to go down? And I'm going to tell you that it's going to increase. Why does it increase when I'm dehydrated? Common sense says it should decrease. So there's this compensatory mechanism. It's compensating. So when your volume decreases, there's less oxygen to the tissues. If the brain has less oxygen, it tells the heart to increase the heart rate. The worse the dehydration, the faster the heart rate. What happens to your blood pressure? Your blood pressure actually goes down. Again, it's a compensatory mechanism that makes it go down. So what is blood pressure? It's the pressure against the blood vessels themselves. Is there much volume to put pressure against those vessels? So even when your heart rate goes up, it's still not pumping more volume, right? Because we have less volume. Your blood pressure is going to go down. Postural positioning becomes an issue. So when they go from sitting to standing, they could become dizzy or even pass out. What is the skin color? What happens to the skin color? Remember, we've talked about oxygenation to the brain, the heart rate increases, the blood pressure decreases. A lot of times your skin color is going to be pale, maybe even cyanotic, because we just can't get enough oxygen to our blood system. What happens to our skin turgor? The mobility of the skin, because of the fluid, tents it. So if you're dehydrated, you're going to tent it, right? There is less fluid getting into the skin because we have less volume. The quality of the pulses, either centrally or peripherally. If I check a radial pulse and I count 60, and then I check a carotid pulse, what would I expect if my patient is dehydrated? They won't be even. So why is that? I have to save my vital organs, and it's going to shift the blood from the extremities into the vital organs. So you're going to feel that peripheral pulse, and it may be weak, but you will be able to feel it. But you go to that central pulse, and it's going to be more fine. Then you know that the body has shifted the fluids to save the vital organs. All of these symptoms may vary depending on the severity of the dehydration. So let's talk about clinical manifestations of dehydration when we're talking about our respiratory system. What are some respiratory changes? We have an increased respiratory rate because the lungs are trying to compensate. So our patient's going to be tachypnic. If my brain recognizes that I'm not getting much oxygen and I'm hypoxic, it increases our respiratory rate. But are those good quality breaths? Not typically. They're very shallow. Their work of breathing is increased. Does anyone know what that means? It means they're using those accessory muscles. You can see the ribs when they breathe. Their nares may be flaring. You're just going to see a lot more work of breathing. We're breathing fast, shallow, and ineffective. So what happens to our pulse ox if those things are happening? We know it's going to go down. What are some neurological changes that we can think about? Our mental status, what happens in the brain. We're going to have changes in our level of consciousness. It may start with a little confusion. As they become more severely dehydrated, that's going to get worse. We can ask very specific questions. Who am I? Who are you? What's the place? What's the time? What's the situation? Right? Person, place, time, situation. And then we can say they're alert and oriented times 4, or maybe they're just alert and oriented times 2, which would indicate some confusion might be going on. It may be little things. Remember being in the ER, but not able to remember getting to the floor. Very subtle, very slowly. We need to make sure we're keeping an eye on those mental status changes. And then what happens in our renal system and our kidneys? What is the trend in our urine output? What's going to happen to our urine output? When you don't have enough circulating volume, it's going to shut down that urinary output and start reabsorbing it. So we will have a decrease in urine output. As that urine output decreases, what happens to the quality of the urine you put out? It's more concentrated, it's dark. And is this a good thing? Absolutely not. It can actually do permanent damage to our kidneys in a really severely dehydrated patient that doesn't take care of themselves. So again, these are just more signs and symptoms of fluid volume deficit. And I think we went over most of those with our infants. If they're crying, they don't have tears. They may have really dry skin, dry mucous membranes. They may not have any wet diapers. If they're complaining of constipation, right, we need lots of water to keep our elimination good. So just some other ones that you could consider. So what about labs when we are dehydrated? Let's look at our electrolytes. What about sodium? What is happening with our sodium level? It usually increases. If I'm losing water, then I'm concentrating my sodium. The electrolytes are more concentrated. What about the renal function? What is happening to my kidneys? We're going to look at the BUN. We're going to look at the creatinine. BUN will rise first, and then creatinine will elevate as the dehydration gets worse and the kidneys become more damaged. What about hemoglobin and hematocrit? These are also going to increase because they're going to increase concentration in the body because of the fluid loss. So why does it go up? It's hemoconcentrated, right? Because we have low volume. When we give fluids and we draw labs the next day, the hemoglobin will significantly go down because we've rediluted the hemoglobin. And then serum osmolarity is an increase the concentration, so this is going to go up. We don't have much circulating blood because of that fluid loss. So our serum osmolarity is going to increase because the concentration is going up. So how are we going to manage these deficits? We've talked a little bit about this already, right? We're going to check our I's and O's very strictly. We're going to draw some labs. We're going to do some assessments. We're going to do our daily weights. And then we're going to make sure we're taking care of any skin breakdown, good oral care. And we're really watching these patients for any developing complications. So now let's look at clinical manifestations of fluid overload. Now we have too much fluid. So what is that patient going to look like? Fluid overload just doesn't happen. If I decided today I was going to drink 6 liters of water, could my body handle it? It absolutely could. It could tolerate that today. So who is it that goes into fluid overload? Our heart failure, our cardiac patients, our kidney failure patients. maybe our patients that have something wrong with their endocrine system. Basic healthy people don't go into fluid overload. So let's start with the heart. Your patient is in fluid overload, meaning, again, there's too much fluid on board. What happens to the heart? What happens to the pulses and the quality of those pulses? They become tachycardic, and they typically have those very bounding pulses, right? We have too much fluid getting around in our body, and we have a heart disease, meaning we're tachycardic because there's so much fluid, and our pulses are very bound. What's going to happen to our blood pressure? Is there a lot of pressure against the veins? Yes, there's lots of fluid, so we're going to see an increase in our blood pressure. What about the soft tissues, the conditions of our extremity? We're going to start seeing some edema. All the edema is going to start happening, and we call that hydrostatic pressure. When we have so much fluid in the intravascular space that it can't handle it, it starts forcing those fluids through the vessels into the surrounding tissues, and that causes that edema. Where would you see this shift? The first things you're going to see when you see that edema, you're going to see it in their hands and their feet, probably in their face, eyes, abdomen. We call that ascites. We may see it in our lungs or hear it in our lungs, and we may also see it in our neck veins. If we have our patient turn their head, that neck vein is going to really bulge out. So what are some respiratory changes that we might see? What is happening in the lungs? Is our breathing really effective? When I listen to the lungs, what do I hear? I'm going to hear crackles. They're going to be nice and they're going to be wet lung sounds. Are their breaths nice and deep? Not really. They're still pretty shallow. So now we have wet, shallow, crackly breaths. What about the brain? If we focus on our neurological symptoms, how does the overload affect that? There's still going to be some alteration in our LOC, our level of consciousness. They're going to have confusion, and the more the overload, the more confused. Again, this one's very similar to dehydration, but you can also have some other symptoms that might fall into this neurological. What do you think their head feels like with too much fluid? They're going to complain of headache because there's so much pressure. Headaches to the point it may affect their vision. What happens to their muscles? It can cause weakness due to the electrolytes that have shifted. So we've talked about all the fluids moving from the vascular space into the interstitial space. The hands, the feet, the face, the eyes, the abdomen, the lungs. But it can accumulate in other places like the liver and the spleen. We call this hepatomegaly and splenomegaly. This isn't a permanent change unless it lasts for a really long time. So we need to get those fluids off so that we don't have liver and spleen damage. So again, here's a recap of symptoms that we can see with overload. This is too much, right? Neurological symptoms can happen, respiratory symptoms can happen, cardiovascular. We can have some gastrointestinal symptoms such as nausea, not really feeling like they want to eat. You can see our young man there in the middle with just all the fluid all over them. You can see that edema. So we want to just make sure that we're getting some of this fluid off. As far as lab findings for our overload, what happens to our electrolytes? The electrolytes are going to decrease because they're so diluted. Our renal function is going to increase because the kidneys aren't getting what they need, right? All the fluid's going into those interstitial spaces and not into the kidneys. The BUN and creatinine is going to rise. Our hemoglobin and hematocrit is going to decrease. And our osmolarity is also going to decrease because we just have too much fluid. So now we've looked at some of our fluids, our electrolytes, our overhydration, our dehydration. Actually, now let's look at some of those electrolytes. There are several different electrolytes, and it can be very extensive. We're going to really focus and look at two of them and that's going to be sodium and potassium. You're going to add more as you get into your HR classes. When we think about electrolytes, we think about them as cations or anions. Cations being the positively charged electrolytes. So sodium, potassium, calcium, magnesium, those are your positively charged electrolytes. Our anions are those negatively charged electrolytes, chloride, bicarb, and phosphate. So let's look at the basics of what our electrolytes do for us. I want you to fill in these blanks and see if you know what your electrolytes are doing for you in your body. So the major electrolyte in our extracellular space is essential for acid-base balance. It can cause some irritability and conduction of nerve and muscle tissue. So what electrolyte is this? That is our sodium. Sodium is all about muscle tissue and conduction because it lies in the extracellular fluid. It's usually a bigger number. The normal ranges for sodium are 135 to 145. Bigger number because it lies in that extracellular fluid. So the next one is, it helps with cell metabolism, transmission of nerve impulses. It lies outside of the normal range, or if it's outside of the normal range, the major concern is a cardiac rhythm. So what electrolyte is that? This is the one you're concerned about, the heart. If you get too much, your heart's going to work overtime and you could potentially die from this one. So that electrolyte is potassium. Potassium is a big deal. If it is even the slightest out of range, we need to get worked up about it. It's an intracellular electrolyte and should be a small number. So the normals for potassium are 3.8 to 5, so an average of about 4.5. Remembering a slight change in this number can affect your heart. The next one is nerve impulse, blood clotting, muscle contraction, bone and teeth formation. And this one is, the next one is mostly found in bones, vital action involving enzymes, and that one is magnesium. And that last one is bicarbonate, which is the body's primary buffer system. Again, we're just going to focus on sodium and potassium. You'll get more information in your HR classes on those other ones. So what are some common electrolyte imbalances that we might see? You will need to know this terminology. Hypo means low, hyper means high. So hyponatremia is a low sodium. Hypokalemia is a low potassium. Hypocalcemia, low calcium. Hypomagnesemia is a low magnesium. Hypophosphatemia is a low phosphate, and hypochloremia is a low chloride. And then you just have the flip if it's high and you need those hypers. So here's also the normal values for each of those. Remember, sodium lies in that extracellular fluid, so it's a higher number, 135 to 145. Potassium lies in that intracellular fluid, so it should be a very small number, 3.5 to 5. Remembering if our potassium is out of range, we need to be concerned about cardiac issues. So some common medications that we can that can cause fluid electrolyte or acid-base imbalances. A lot of these medications are the reasons we have these imbalances. And some of these may look familiar to you from pharmacology class. Our ACE inhibitors for our cardiac are common in our population for over 65. Our corticosteroids are commonly given for inflammation. Our diuretics are usually given to get that fluid off, right? So we have to watch those potassium levels. Laxatives, non-steroidal anti-inflammatory drugs are NSAIDs like ibuprofen. If we use those long-term, it can cause some electrolyte issues. Penicillin is another one. If your patients are any of any of these medications, it just should be a red flag that imbalances could occur. So just be aware of that. So some lab studies to assess for any imbalances. What are some labs that we want to look at if we suspect an imbalance? We're definitely going to get our CBC, which is going to tell me what's kind of happening, what could be contributing to my imbalance. Electrolytes are going to tell us those values. So what are our kidneys doing? How are they working? Our urine pH and specific gravity are going to give us some information. And those ABGs are those arterial blood gases. This is going to talk about the pH in your blood. And we're going to spend a lot of times talking about ABGs tomorrow. So some nursing interventions that are going to vary, really depending on the imbalance that the patient has. You're going to really focus on these a lot in the next module. So I'm just going to move right through these. Dietary modifications, fluid intake, medication administration, we've talked a little bit about that, right? IV therapy, we need to make sure we're giving the right solution. If we have to replace our blood or blood products, that could throw off some of the imbalances, so we're just being aware of that. Anxiety, reducing our patient's anxiety, right? If we're breathing more, we're getting rid of insensible fluid, and then making sure we're just teaching our patients. So let's put our nursing process kind of into play here. We're going to talk about physical assessment. We're going to get those daily weights, and we're going to have our strict I's and O's. And we really already talked about some of these things, but remember this part can really be very important and impact our patient. Rapid weight gain can tell us a lot about our kidney function. Kidney function has a lot to do with our electrolytes. If our patient is in heart failure, they're going to retain weight, which can affect those electrolytes. So remember, we are being mindful about our physical assessment and what are we really looking at. So let's look at some risk factors for hyponatremia. Remember, hypo, low, natremia, sodium. So we're talking about our low sodium patients. So if we're talking about abnormal GI losses, what does that mean? That means diarrhea, that means some vomiting. We also talked in Concepts 1 about a procedure that could actually contribute to hyponatremia, and those are our ostomies. Specifically those really high ostomies, right? Like our ileostomies. Those electrolytes are not being able to be absorbed because it's just coming right out of that ostomy, which could be a risk factor for hyponatremia. What about our NG tube to suctioning? Remember, if we have an NG tube down and we're suctioning, it's almost like vomiting and we're losing all of those fluids. What about our enemas? A tap water enema could cause a shift or an imbalance in our sodium levels. What about our renal losses? What could cause a loss of sodium through the kidneys? Sometimes we can think about medications like our diuretics. If our patient has kidney disease, those kidneys are just going to stop reabsorbing the sodium and it's just going to get wasted. Edema can cause hyponatremia because of the shifting of the fluids. Edema due to heart failure, liver failure, or kidney failure is going to decrease our sodium and cause us to have a risk factor for hyponatremia. If we're giving too much hypotonic solution, that can cause hyponatremia because of the shifting that's going to occur. So let's look at our older adult. What can happen as you age that causes hyponatremia, right? They're on lots of medications. That's usually commonly what we see. Lots and lots of meds for that older population. So we want to make sure it's not the medications that are causing that. Look at their meds, reconsolidate all of their medications and see if that's what's the cause. So let's flip and talk about hypernatremia. Remind me, hypernatremia, hyper too much, natremia sodium. So we have too much sodium. So water deprivation, meaning we're NPO, sodium can be very concentrated. So that's going to maybe increase those levels and cause us to be hypernatremic. A heat stroke, we're losing water at a faster pace than the sodium. Excessive sodium intake. There are some statistics in the United States. About 70% of adults live in a state of hypernatremia because we salt everything, right? And if we're not salting it, it's high in our processed foods, our fast foods, our TV dinners, right? There's lots and lots of salt. So we may be living in a hyponatremic state of mind and don't even realize it. Excessive sodium retention. So why would we retain sodium? Some of our endocrine disorders, kidney disorders, are going to tell our bodies just to hold on to that sodium. And then different fluid losses. If we're over sweaty, we're breathing too fast, we have burns, that's going to be a risk for our hypernatremia. Hypernatremia is also a problem with our older population because most of the time they're not drinking enough. They have more trouble making food, so they're eating a lot more of those processed foods, which is increasing that salt intake, which is increasing our sodium. Older adults also have a lot of change in their taste buds, so we're going to see them add a lot more salt to their foods. So let's move into hypokalemia. What does that mean? Hypo, low, kalemia, potassium, meaning we have low potassium. What causes shifts in my potassium to be too low? You will see some similarities that caused my sodium to shift. That's also going to cause my potassium to shift. So those abnormal GI losses, those renal losses, skin losses such as diaphoresis, if we have a big old wound that we're losing drainage from, that could cause some hypokalemia. Insufficient potassium intake, inadequate dietary is usually rare but can happen. Prolonged administration of some non-electrolyte containing IV solution, such as 5% dextrose in water. A lot of times if we see sodium go low, we're also going to see potassium go low. On the other side is our hyperkalemia. Again, we're going to see some similarities, but a couple of differences that I just want you to point out. Remember, hyperkalemia, hyper, high, kalemia, potassium, so high potassium. One of the things that people don't often think about that causes hyperkalemia, again, is that dietary intake. People are told you can't have salt, so what do? They buy salt substitutes. And what are those high in? Potassium. So then they have too much potassium because they're overdosing on it when they told them not to have any salt. Diabetes is the other big one that can cause some hyperkalemia. Remember, if our potassium is out of whack, we get concerned about cardiac. So differences here in hypo and hyperkalemia. Potassium is all about nerve impulses. Sodium is more about muscle irritability. Potassium is all about transmission of those nerves, specifically the heart. On the low side, we see heart problems. On the high side, we see heart problems. When it comes to potassium, it doesn't matter which way you go, it's going to cause some heart problems. So if I would ask you a question on the exam that stated potassium is out of range and asked you what your priority is, you better say cardiac. Heart is always the answer when it comes to potassium. I'm not going to go over this slide. Just know that heart is still a priority when we're talking about kalemia. And that sums up this chapter. If you have any questions, please shoot me an email. Otherwise, we're going to chat about it in class. Thanks, guys.